Great. So today I will try mildly introduce what is digital pathology and show you a few successful use cases which are very applicable for AstraZeneca and I'm sure other pharma companies. So let's start. What is AI? Yeah, it's Accelerator Institute, and also it's intelligence demonstrated by machines, whether natural intelligence is demonstrated by humans. And AI scientists, they're working on AI research, and computer vision is one of parts of AI research. And I think many of us are trying to get a step closer to general intelligence. It's our long-term goal. And this I think you heard many times, and machine learning is where we teach machines. Machines learn from data, and we apply different machine learning techniques on our data. So then, like an algorithm can predict something, for example. And deep learning is, if you ask me, I would say it's like machine learning on steroids, but it's kind of subset of machine learning where we use like neural networks with a lot of parameters, and these models actually they showed, at least so far, as far as I know, like deep learning is state of the art in many computer vision applications. And of course, this sort of approaches, they are very data hungry, so we need a lot of images. But the good thing is, like these days we're getting more and more data, so I think there is more promise in deep learning in general. Also, deep learning is state of the art for segmentation, classification tasks, detection. I think you've seen yesterday, today, all these possible tasks, and we kind of interested, for example, identify some specific area or segment out a specific object, or even like to some instance segmentation where we want to identify, give names to every single object and also outline it. And in medical field, semantic segmentation is very common. It can be from CT imaging segmentation, whether it's a human or a mouse, you segment organ, and then once you segment organ, you try to see if there's any pathology or it's normal. Ultrasound, data also, you can even reconstruct like baby face from, let's say, using ultrasound signal from a pregnant, let's say, woman, for example. And MRI imaging segmentation is also kind of, you can get like different parts of brain segmented out and even understand, try to see what kind of signal propagates if people, for example, are exposed to some stimulus. And also there's histopathology images, which I'm going to talk today. Histopathology images is very related, for example, for cancer. And let's say if a person is suspected to have cancer, then a biopsy is taken, and then pathologist would look at this biopsy and before it and investigate every single cell in this biopsy, and for that we need histopathology images. What kind of excites me these days that there are more and more public data sets available. For example, on Grand Medical Challenges website or on Kaggle, and in 2017, for example, was a challenge where one could get like 1 million in prize money. Actually, it was, I think, split across first, second, and third place, but the task was to segment out in CT and MRI scans, like let's say lung, and find some cancerous nodules, if I'm not mistaken. So definitely, like deep learning is making a lot of change and revolutionizes the field. And pathology is one of branches of medicine, which actually pathologists are humans like us, and their job is to examine, for example, a biopsy under the microscope and say if it's cancer, no cancer, what type of cancer it is, grade, and so on. And like it's called like microscopic examination of tissue specimen. For example, taking a biopsy from lung cancer patient and then prepare like a staining, because like tissue is transparent, so you need to stain it with so-called hematoxylin type of dye, which is like 100 years old technology, so you can see different cells, different morphology, and then you can analyze this sample under the microscope. These days, there is also advances, of course, happening, and for example, you can stain also for, like let's say, tissue for expression of specific protein. For example, immunohistochemistry enables one to look into some specific protein expression. And of course, like genomics, like with the revolution in whole exome sequencing getting cheaper and cheaper. And you can also take a small piece of tissue, sequence it and count some mutations and see what's kind of mutations that patient have, and then adjust treatment, or like kind of already know, like say, what's the chances of the patient to for survival or response to different types of treatments. So since I would say quite recently, since you have these H&E slides, they can be scanned at high resolution. And by high resolution, I mean it's like 100,000 by 100,000 pixels. So one scan could be like billions of pixels. So it's a lot of information, different cells and hundreds of thousands of cells. And once you have these images, you can apply artificial intelligence, you can apply computer vision algorithms, and train different algorithms to detect some specific cancer cells or even cancer regions, or it's a lot of research is happening there, and it's actually what I'm working in these days in AstraZeneca. And I would say pathologists and AI scientists, they come from quite different worlds, and they already collaborating quite closely. And as a result, we have many successful projects, many unicorn companies like PathAI, Page, and you name it, appear due to this fact. And at AstraZeneca, we are learning to speak the same language. For example, my background is computer vision, and sometimes I can go to a pathologist. Actually, when I started working in this field, and I say like, fully convolutional neural networks reach like F1 score of blah 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 on the test set, and pathologists like, what you're talking about, and same pathologist can say, oh, IHC stained primary tumor specimen, demonstrated highly overexpressed HER2 protein, and in the beginning I couldn't understand. So it's kind of learning process. But once we learn the language of each other, then we can develop amazing algorithms which change patients' life. And what do AI scientists? Kind of what are their main tasks at AstraZeneca, for example? It's just part of it. Like we develop different deep learning applications, frameworks, on whole slide images or any other images, and we predict different types of cancer, different types of cancer stages, and segment out, classify. It could be regression, predict what's the kind of expected survival of that patients, and we apply also different types of algorithms for different types of cancers. Of course, like supervised learning is very powerful, but the problem in medical imaging that we don't have ground truth quite often, or we have like only kind of labels on whole slide image saying cancer on cancer, and for example, if I look at this image, I cannot say if it's cancer or not. So we really rely on domain experts such as pathologists. But these days also machine learning is quite advanced, and we can apply like weekly supervised learning, or even unsupervised, try to kind of group patients and see actually if there's any difference between different patients based on their images. And AI already revolutionized. Of course, like ideally we want to prevent. We don't want to kind of take a biopsy for a patient and say, oh, it's already too late. We want to prevent. So there's a lot of research where like you can detect, let's say, some precancerous conditions and make an action, and it requires a lot of images, of course. Just an example of successful like such as algorithm, like it's 60,000 images collected and then pathologist notated, and then you can prospectively evaluate the performance and get quite high, let's say, even like on par with pathologists sometimes. And of course, like, again, the goal is to help pathologists because many of them, they're overloaded with work and number of these routine tasks. And for example, for prevention, potentially like 90% is normal. For diagnosis, also very important. And one example is like predict, for example, lung cancer. Lung cancer, again, from biopsy, you can predict whether it's lung cancer, but also what type of cancer. For example, there is squamous cancer, is adenocarcinoma, and many different subtypes. And we learn more and more about cancer, and we are moving towards kind of having even more granular types of cancer diagnosis. Then treatment, of course, like the main business of AstraZeneca to develop, to produce new drugs to treat different diseases, and we already using AI at different stages. From target identification, like find which kind of, for example, protein is responsible for cancer growth and kind of suppress it, or to like clinical trials, what patients to select, kind of to optimize that we select the right patients and provide these right patients with the right treatment. And again, this personalized medicine depends on patients, like let's say profile, for example, genetics profile, we can assign some specific treatment for this patient. One example I would like to highlight, for example, what is cancer? Cancer is like something, some mutations happen in our genome, and for example, there's one well-known gene like called HER2, which actually, if mutation happens in this gene, then cells, they start kind of multiply, cancers multiply, and then eventually this person will die. But what can be done if you know that this patient has mutation in this particular gene, or that gene actually overexpressed? Then we can kind of push it down and stop the spread of cancer. And actually, there are therapies developed for so-called anti-HER2 therapies, which help to treat HER2-positive breast cancer patients. So it means, like, if a patient has breast cancer and you identify that that patient has overexpressed HER2, let's say protein, like in this kind of slide staining, then you can assign this patient to a specific treatment, and the patient will benefit for it by potentially surviving or at least living a longer life. But one bottleneck that pathologists, they need to look under the microscope and say how that let's say patient how much, let's say, overexpression is there, so kind of quantify to some extent. And this is an example how this staining looks like, and it's immunohistochemistry staining, so it means it's a specific staining for this specific protein. And there is a scoring system. Again, change is quite continuous, but need to score and make a decision. Decisions, they are usually black or white. Give this patient this type of medicine or don't give. So you need to find this kind of cutoff, and then there is kind of a way to grade from 0, 1, 2, 3, and pathologists do it. And then actually, of course, potentially can develop an algorithm, right? So first, there are like algorithms being developed, or like Grand Medical Challenge organized by Warwick University, for example, to predict this HER2 score directly from IHC slide. But as I showed before, IHC is also quite advanced compared and not kind of gold standard of pathology, which is like H&E, like kind of very old technology, which is cheaper, and you can get potentially let's say results even faster. The problem is pathologists are not trained to to create, let's say, overexpression of HER2 protein from H&E directly. They need IHC. So we worked on developing algorithms to predict HER2 status or HER2 score directly from H&E, and we are getting promising results and result of research. So just kind of give you an idea of what's the future. Take simple, potentially H&E staining, which is gold standard in pathology, and then you can predict many things like mutations. You can predict overstaining of particular protein. You can, predict many things and assign the most efficient treatment. Yeah, so so we can help pathologists a lot, and this is examples. Yeah, so for example, we can find where cancer is. So instead of pathologists look at this huge slide, we can say, look here, here's the cancer, and kind of try to understand more, so we can kind of guide pathologists where to concentrate their attention. And sometimes, for example, in prostate cancer, a gland can be tiny, and it's very easy to kind of miss it. So this is one example. Just to give you an idea, so like the whole slide image is huge, and that tiny gland can be like just, I don't know, like less than a millimeter, or like a few micrometers in length. And then like we develop some algorithms that can predict quite accurately where the gland is. And we saw like examples when pathologists could even miss this. And in the middle you can see annotation of by a pathologist who didn't miss it, and it's kind of very similar to what the algorithm predicted. And again, this algorithm never seen this H&E image. As I mentioned, very often it's kind of the ground truth, so-called ground truth. It's not like black and white. So even cancer, right? It's kind of like continuous change, and even so, like labels are very noisy very often. And on top of that, very often we don't have detailed annotations. We have only slide level annotations. So for example, whole slide image, and we know that it's coming from patient with cancer. We successfully applied weakly supervised learning, where you can not only let's say predict from this label, slide level label on unseen data, but also find some areas of attention which we then show to pathologists, and in many cases it would mean something. So for example, that area would associate it with cancer, or it's not only about cancer, it's about different diseases where you can find, for example, inflammation or some malignancy. I'm sure Phil yesterday presented very nice. Also, explainability and interpretability is a big thing. We don't want just predict, we want to kind of understand what the model learned. One challenge is, of course, very often our data is quite biased, and we ideally want an algorithm which generalizes for all kind of data, all kind of, let's say, cancers. But the problem is, I wouldn't say problem, it's actually, it's our world is dynamic, so practice changes, it improves, becomes, technology changes. For example, these H&E images, they're scanned with a scanner. Scanners, they change, there are different vendors, and the tissue is prepared, by humans. Humans prepare it differently. It stains already by robots, but for different types of robots. We always, especially when we work on clinical trial data, we have very limited data set. And when you go to real-world evidence data, then the data is messy. It's so there's no kind of easy way to solve this problem. But we're definitely getting more and more data, and our models become more and more better in generalizing. And as I mentioned, it's very hard to interpret digital pathology predictions, because it predicts something. If you have ground truth, it's great. You can say it's cancer, no cancer. But what the model learned. In our case, we work very closely with pathologists, but at the same time, we are exploring different advanced methods, try to see, how the model, let's say, for example, reacts to some adversary attacks, or if we change something in input, or I think Phil covered this topic also quite well yesterday. So just to kind of summarize what you can do already with AI in digital pathology, you can predict cancer types and subtypes. You can try to see where the model, let's say, focuses, what it takes decision based on what kind of, let's say, areas, and eventually we want to deliver patients with better and faster, more accurate diagnosis and treatment. Yeah, thank you.
For such a good presentation. I have a couple of questions. It appears to me that your overall presentation was based on the fact that we can classify or identify the cancer tissues in different parts of the body. I was wondering that in reality, while you are doing identification or the classification of the cancers, then it varies from person to person. So what do you suggest in order to implement any kind of AI solution or any kind of AI classifier? How can you overcome this problem of the data labels for particular cancer tissues?
Yeah, I mean, eventually we get more and more data sets and more labeled data, right? And, like, for example, one way potentially to overcome is, to have some sort of active learning, yeah? When you kind of train algorithm and then, let's say, you don't have labels, but, for every 10th prediction, you still can kind of ask a human to provide some kind of feedback and, iteratively improve the model. And eventually, I mean, we still rely on, humans to kind of like domain experts who can provide, like, let's say, feedback on the model and, kind of, we need to feed it back. So I think, like, yeah, we can kind of optimize it the way we get more and more annotations and more kind of labels, so-called ground truths. But I think, like, it's kind of one of bottlenecks. And how it started, we needed like very detailed annotations. Now we already have some models, and we can ask, let's say, pathologists or other domain experts, like, to provide some feedback on that model, right? Or on, what it kind of tells, predicts, and, then we can increase our training data or potentially relabel it. But I think it's still very important to keep humans in the loop so far.
Following this question, my second question is, because this is what I am doing these days. At the moment, what it appears is that we are doing a kind of a static classification. And suppose, especially in the human body, if we wish to use computer vision, for example, determination of the heart rate, which is not just the classification, it's a kind of animation. So do you have any comments on it or any suggestion on it that how we can implement AI towards that direction?
Yeah, I mean, as far as I know, I haven't worked that much on these kind of problems, but like, of course, like wearable devices, especially for aging populations, are very important, right? And, of course, like, yeah, you can have some device which is connected to like doctor or some emergency services, right? And, potentially it can predict ideally predict something what would potentially happen in the future, not kind of just, kind of tell you, okay, something happened, the heart rate stopped, right? You want to kind of predict something. So I think it's definitely very interesting, and I'm sure there's a lot of research going on already.
I have a question. Thanks for the fascinating talk, and a lot of the issues you raise, like we're facing also daily. And just have a question about, you were showing, for example, the HER2 classification to the different grades, and like now Astra also has this new drug that works on HER2 low, which is very novel and new. And like one of the issues that we face is, and you mentioned this later in the talk, is this variation between different laboratories, between different trials in the type of data that you receive, right? That the model receives. And if you had any special ways that you are dealing with this variability in the data, because, for example, if somebody creates a tissue slice that's 4 micron thick instead of 2 micron thick, or they use a bit more staining or something like this, then it really can affect this readout of the algorithm.
Yeah, I think it's a very challenging problem in general, because like there are so many parameters, right? It's like demographics, and every human is like unique, right? Every cancer is unique. And then like on top of that, tissue preparation. So, usually we can take one parameter and try to kind of control all other parameters, right? Like, for example, this scanner, right? We have that, let's say, data set. We scan it like with one scanner, another scanner, and then we can kind of explore, this variability or tissue thickness. I think for kind of like demographics, it's much more complicated, right? Because, I mean, the power of these algorithms, they need a lot of data and, a lot of variability. And if you take whole slide image, it's like billions of pixels. But how much variability is within that sample compared to kind of other samples? And on top of that, in real world, we mostly have biopsies, right? And, if you see like in the literature, many algorithms are trained on resections, a huge pieces of tissue. And performances are nice, but when you go to real world, and for biopsies, it won't work. And it's something I think the community is trying to solve, but I don't have a solution for this.
Question about this. So you mentioned here like this work for trying to predict these classes from H&E directly. And do you think that this will actually be able to come to the clinic? Like looking at the results that you can achieve for HER2 classification based on H&E, do you think this has like a path forward? So, for example, this eliminates a lot of the variability that we see in IHC.
I think it's still research. So I don't know if it will eventually end up like, let's say, in clinic, but I think a lot of work in H&E space trying to squeeze out as much information from H&Es, right? Because it's still gold standard. Like any cancer patient or like any kind of malignant patient with some abnormality, like a biopsy will be taken most likely, and then it will be analyzed by a pathologist. It's still gold standard. So the more we learn about H&E and the limits of H&E, I think the better. So potentially IHC won't replace, maybe in 5-10 years, genomics replace everything, right? Maybe. So I don't know.
Thanks.
I think if no more questions, thank you very much.